So thank you very much, Tanshu sir, for having me in your course, sir. And it is PCR and PCR and how to do or how to manage a PCR and the intraocular lens implantation. So all is actually not lost. And if all is not lost, so how do we go about it? So what we do at when we encounter a PCR and when PCC is impossible. So the first dictum is, if there is a PCR, can you do a PCC, a posterior capsular rhexis? And if it can be done, that would be the best thing. But in this case, there's a large PCR and the cortex and the nucleus is all there. So a PCC is definitely not possible. So what we would do is to fill in with high molecular weight viscoelastic, push back the nucleus far back as much as possible, have as much as possible, have as much possible viscoelastic into the anterior chamber, as little turbulence as possible, and all the time injecting the viscoelastic and removal of the phaco needle with viscoelastic in place. So here is a situation where I think there is not much of vitreous prolapse into the anterior chamber. If it prolapses, if it happens, then definitely we need to do a vitrectomy before going on to any part of the procedure. Remembering the fact that if vitrectomy is not done in time, what is going to happen is the vitreous is going to pull on its base, and a possibility of base trouble, a tear in the retina, in the periphery is a possibility. So placing here the intraocular lens in the sulcus and putting it in place with here you can see that there is an amount of vitreous which actually is not so visible when you see from outside. Therefore, you need to put triamcinolone. You need to see whether there is vitreous into the anterior chamber, and this should form a rule before you close up the case. And if there is vitreous into the anterior chamber, you need to do a vitrectomy, nicely cleaning up, which is not so difficult at all. Let's go to our next scenario. And when the posterior capsular rhexis is possible. So what do we do when a posterior capsular rhexis is possible? And look at this case in which everything was going so nicely. But unfortunately, when I thought that everything has gone on well, we suddenly come up with a situation in which I see that there's something wrong that has happened. And here we put in viscoelastic into the anterior chamber as much as possible. And you can see it's a very, very small posterior capsular rupture. And with this small amount of posterior capsular rupture, very nice posterior capsular rhexis is possible. And once that is done, this bag is totally stable. So in the previous case where we placed intraocular lens in the sulcus is not required here. All that we can do is, if we have planned for a single piece lens or a multi-piece lens, both these lenses can go very atraumatically into the anterior chamber. You do not have to worry at all about the integrity of the bag at all. And once it is placed nicely, as I say, and do as well, that we need to see whether there's any vitreous into the anterior chamber at all or not. So the next part is this PCR in the small pupil. And as you can see, it has been a very, very difficult situation for me. You can see there are 5 hooks there. I've created a posterior capsular rupture and I have to repair it. So when I have this posterior capsular rupture, then again, trying to do a PCC there, and I've been able to complete this PCC and look at this amount of vitreous that there is into the anterior chamber. So in this particular situation, we definitely need to do a vitrectomy, and you can see that the vitrectomy is being done. One small advice to everybody who does a vitrectomy in these cases: you have to marry the irrigation to the vitrector. You have to see that the fluid infusion is taking place and the amount of viscoelastic is not such that you're actually not cutting the vitreous and you're just about cutting the viscoelastic. So the vitrectomy has to be done as nicely as possible. And once that is done, the next part becomes easier. We just need to put in the intraocular lens in its place. And here it's a stable bag. And once the intraocular lens is there, you just have to capture it. So the capturing is very important to stabilize this intraocular lens inside the bag. And once stable, this is going to stay stable for life. And of course, you can see the ovalization of the anterior capsule as it is captured. So again, vitrectomy, and you can see these strands of the vitreous which become very visible when you put in triamcinolone. And you can see, of course, it's been a very tough situation, 5 hooks all there. And you can see that there is atrophy of the iris as well. But things will go well if it is done to the best of the advantage of the patient, and usually the recovery is good. Now, here is the situation with PCR with the nucleus and cortex that there is. And in this case, we have the nucleus in place, and I've created this PC rupture. And with this PC rupture, we need to be aware that we have to place in as much as possible the viscoelastic. And again, here, it is also possible to do of this posterior capsular rhexis. So the posterior capsular rhexis forms a very important part of a PC rupture unless you have it in that first situation. Here, what I need to show you is the removal of the cortex is also very important. If you can atraumatically remove the cortex without having the aspirating on the vitreous, if you're 100% sure that there is no vitreous into the anterior chamber. So this is the way to go, placing in viscoelastic all the time. And you can see I've left behind a little part of the nucleus. So I first wanted to put in the lens, and because this is a very stable capsular bag with a posterior capsular rhexis done, I wanted it to stabilize well inside the eye and then remove that part of the nucleus that there is. So a little bit of a scaffolding technique. However, the actual scaffolding technique in which a large part of the nucleus is still there. But this is just that I wanted to make sure that the lens is in place before I remove the part of the nucleus that was there. And of course, doing a vitrectomy with triamcinolone as and when required is important. Now here we have a situation where posterior capsular rhexis is absolutely not possible. And can we still put an intraocular lens in the bag? So in this situation, I'm going to show you this one and have a look. This is a PCC and this is a posterior polar cataract which has ruptured, and I'm just going to halt it in 1 or 2 places just to make sure that we are getting the right steps. So here is the place where it was a PCC. I was expecting a rupture. We had 2 lenses in place, the single piece as well as the multi-piece lens in place. And in this, it did rupture, and it was a horizontally end-to-end rupture. So look what I'm doing now. Can I place this intraocular lens in the bag, even with a ruptured bag? So there's a small trick and a little bit of a technique. I'm going to show you this, demonstrate it. Now, this is important. So what I did is, with viscoelastic cover, I placed this intraocular lens just there, and adequate amount of viscoelastic over the intraocular lens as well. So it's stable now. But what I did is I injected the haptic, the leading haptic over the iris. I did not venture to put it in the bag in the first place. Having said that, then what I'm doing is I'm placing, just 1 more minute, I'm placing this intraocular lens and then tweezing it inside the bag here, like that. Okay, so once I tweeze it in, it goes into the bag. So once this has gone into the bag, the next part is making a kink once again of the trailing haptic as well. And this positioning is very important. Please mark this position. It has to fold upon itself like an elbow and then be placed into the bag, and that has to be under direct visualization. It cannot be this way and that way. You have to see that it is going between the anterior capsular rhexis and the ruptured posterior capsule. This is very, very important. And once it is there, then everything is much better. So these are the things that I wanted to share with you. And of course, I have a huge number of posterior capsular rupture videos in different situations, in different techniques. But I think with the constraint of time, we'll just end it at this. And I thank Satanshu sir for giving me this opportunity to present in his course. Thank you, sir.